All right. Thank you guys for showing up at 9 o'clock in the morning. I think at least some of you are caffeinated. That'll be good. I hope that this is going to be entertaining and maybe a little bit informative, and so you should feel free to laugh. I'm going to say some things that at least make me laugh. As you can tell, I'm an American, and so no, I didn't vote for him, and yes, I'm sorry on behalf of my country. We will do better next time, maybe. So he already told you a bit about what Quantify does and in my background, so I can basically skip my first couple slides. But the thing that I really wanted to point out here is that we're really talking about machines empowering humans. So despite the fact that we're a tech company and I'm a tech guy, that's only because that's the only skill set I have. Like, the only thing I'm good at is working with computers, and even that is sort of questionable. But really, so none of us believe at Quantify that tech is going to be the solution. Tech is like a tiny piece of the solution. But what I would say is that also none of us believe that there is a solution without tech. And that really, as much as psychology and psychiatry is looking to sort of empower people and to connect people and restore human connections and things like this, there is an element of that. The problems are too large to address without some kind of technology, some kind of ability to scale. So those are the sorts of problems that we go after. And I also couldn't ask for a better setup than Vikram's talk yesterday. So since Vikram's not here to defend himself, I'm going to yell and scream and rant against some of the stuff that he talked about, and in fact talk about exactly these three things. And that was my talk planned from well beforehand. It's just he set me up beautifully for it. So he said a bunch of things yesterday that I rather violently agree with, and then a couple that I sort of disagree with. And so I'll diatribe for just a moment on this. And I'm going to say some things I suspect over the next 30 minutes or something that are perhaps harsh for the psychology field to hear, but they're coming from a place of love. I think there is a lot to be done here, and there's some really amazing things that are possible, but we have to come to grips with some hard truths before we can get there. And so the first hard truth he actually brought up is that we've spent billions of dollars on neuroscience and imaging and genetics and have not seen a lot of benefit from it. And that's exactly true. There is some benefit, and there is some things there, but there's the concern that was brought up yesterday is like, is the same thing going to happen in this digital and tech space? And I don't think that that's the case. And the two big differences there are that the sensors are cheap. Like, they're in some ways democratized. So it's not going to cost you $10,000 to do a scan. It's going to cost you 30 cents in Amazon Web Services fees, right? Like, the actual computation, the actual measurement here is actually pretty cheap. And the other way that this is democratized is that it's not 10 top labs in the country that are able to do this research. It's like 10,000 small companies and a handful of hobbyists. And so that really changes the picture. So the natural thing that comes out of that is it's a mess. There's a bit of a mess in this space in that there's so many ideas and so many people are trying different things and we don't know which ones work. Yes, that's exactly right. And I'm totally okay with that. Vikram wasn't, and the room upstairs wasn't. And we don't know how to evaluate this. But I would contend we don't actually know how to evaluate most of psychology and most of psychiatry. How is this working? So who gets better? Can you tell before someone starts treatment if they're going to get better or not? Who's going to have a long-term sustaining health? Which of these treatments should I apply here? Which one's going to be better for this person? These are all issues and problems, and they're questions that are not specific of technology, they're specific of psychology. And it's sort of generally we as the clinical space, or however it is you concern yourselves, we have to answer these questions, and it's not a tech-specific question. It's not that there are a bunch of useless apps, there's also a bunch of not so helpful clinicians and clinical practices. And so it's not a bad thing, but finding a way to measure all these things is actually, from my perspective, the thing that's really missing and the thing that we're going after. So this is a rough outline of my talk. I'm going to rearrange some of these things. So I'm going to, rather than share how we've done all of these things, I'm going to give you just a sort of brief glimpse as to some of the stuff, the technology that's possible. And I'm hoping that we phrase this, that this is meant to be in terms of framing some larger questions and discussions. And so each one of these things produces what I'll call a gray area, and how it's not, none of this is can we do it. We can do it. We can do all these things. And there's a really interesting gray area around how should we do this? What should this look like? So I talked about my talk is quantifying the white space. And so what exactly does that mean? What I've got here is, I'll describe whitespace in just a second here. We've got one person's interactions with the healthcare system here. So each of these red hashes is one point over the last couple of years that a person has gone to the hospital, the clinic, the ER, whatever it is, and interacted in some way. And so if you're talking about sort of traditional health systems, this is the places that you can take measurements, this is the places that you can affect change, and that's it. But you'll note there's actually a lot of white space there. The time in between the interactions is very important, especially for mental health, right? If you have a broken arm, it's broken whether you're in the clinic or out of the clinic. But when you're talking about mental health, that really a lot of it at its very core is how a person is interacting with the world. And that's not what's happening in the clinic. So in fact, when you're doing all of your measurements in the clinic, you're missing some critical aspects. So to take one quantifiable piece of information here, we have social media posts. This is one kind of thing that's happening outside of the clinic, that's happening in that clinical white space. And we've got a bunch of research that indicates there's a bunch of quantifiable signals present there that are relevant to someone's mental health. So how do we use that? How is that going to be interesting? How do we integrate the data that comes out of these sort of everyday interactions with digital devices and integrate that into care? Spoiler, I don't know. Right? I have a couple of ideas, but this is going to be an evolving discussion. I can build some technology, I can understand some systems, but ultimately this is going to take a cultural shift, and so it's sort of appropriate for this conference. So I'm going to say digital life a bunch of times. Social media is one aspect of a person's digital life, and so what I mean by digital life is basically any time you're touching a device. Every one of us has one of these stupid things. Me waving it around is doing something to the accelerometers, right? There's things that you can measure about the way in which we're interacting with our world by measuring things off of our devices. So I'm talking about things that are sort of passive and pervasive. So it's not a bad thing, right? These things are present, they're being used to sell ads to us already. We should probably use these for some other purposes as well. So I'm talking about some overt signals, that's things like social interactions, posting on social media, and if you're doing anything that you're recording, the quantified self movement is a great example of some of this stuff. Recording your workouts, recording your food, that is sort of an overt signal. You are deliberately creating that record, that digital record. There's also some passive signals that are really interesting. Like, when is the screen active? Is it active at 2 a.m.? Is it active at 2 a.m. in London when you're from the East Coast? Right? Geolocation, and then also like, when is the device charging? That tells you something about a person's life. When do you plug in your phone? When you're somewhere that you're probably comfortable and happy and something like home, right? So that tells you something. So when I talk about digital life, don't think of it just as social media. I'm going to talk a lot about social media and about language from social media, but this is like one instance of a very wide aperture that we can and should be measuring. So I showed you one person's interactions here, the blue and red hashes. Now we have 4 people that I've put up here, and this is meant to say that people are very different. And there are some people for which everything I'm going to talk about is totally useless, right? This person almost does not exist on the social media space. There's nothing to be done there. No amount of algorithms are going to do anything interesting with one post in 3 years. It's just the way that it is, right? But that being said, there are also a whole bunch of people for which they have almost no interaction with the healthcare system. And yet they are creating some of these digital footprints. So how do we use this information to help them? I don't know. I'm going to have a couple ideas, right? The 3 takeaways I hope you leave here with is that there's power in this white space, and this data is actually really interesting, but it's not straightforward. It's going to require some sort of new mindset as to how we approach care. The second is that this is highly individualized, and so to think that technology or treatment should not be individualized, I think is crazy. But there's actually I've got an interesting data point here around what exactly that looks like in ways we can actually quantify a person's individual differences. And the last is that we're really near a revolution in mental health. The data age is coming, right? We can see it, this tide is going to roll over us. And the real question is, how do we want that to look? How do we want that to look, to affect care, and how do we want it to improve care? And I don't have the answers there, but I hope that's let us tee up for discussion at the end of this. This is the eye chart to say I'm not just talking about some product. We've actually put out a bunch of peer-reviewed papers, and we'll continue to do so. We're sort of somewhere in between an academic lab and a company. So anybody who wants papers and stuff, I'm happy to talk about these things. But I would encourage you not to read these. They're not worth anything more than we've done some work in this space. I'm going to talk briefly about suicide because it's a sort of dramatic and powerful illustration of how some of this technology might help. And it very, very, very clearly illustrates some of the gray areas that pop out of the possible use of this technology. So I apologize if this offends anyone. If anybody doesn't want to talk about suicide or hear about suicide, I will not be offended if you decide to go get coffee or whatever it is you do. So this is sort of briefly on Vikram's slide, looking at the mobile phone-based activity with passive monitoring of mental health. This is one aspect of this. So some statistics, and I apologize if they're America-centric, that happens to be where I'm from. I've already apologized for that. But more people are dying by suicide than by automobile accidents or homicide. And any time that the numbers of deaths are this large, this is largely the opioid crisis as well. Anytime that the numbers get this large, there is a national call. In fact, today there was a call from some panel yesterday. I don't know what time it is there, whatever it is. There was a call from the opioid panel to declare a state of emergency because that's how bad that crisis is. And I would point out less people are dying from opioid abuse than they are by suicide. But for some reason, we're not paying much attention to this. It's painful to think about, painful to talk about, shameful, I don't know what it is. But this is a huge problem, and this is meant to drive the point home that's larger than most people realize. This is not an American-centric problem. There are similar stats for almost every country. This is sort of troubling, though. And so this is a direct quote from a paper, a 2016 paper, that experts' ability to predict if someone is going to attempt to take their life is no better than chance and has not improved in 50 years. We're doing something wrong. So a different paper from last year also says that, and this is sort of new, this is really new information, that actually most of the final steps of a suicide attempt they should be measured in hours from the attempt, not days or weeks. So if you're talking about meeting somebody every week for a clinical appointment, it's distinctly possible that progression from ideation to action happens in between those visits, and you'd have no way of knowing. Right? So this is a point that we really need some real-time data. And the only way we're going to get that is through this sort of passive collection. And using some of the smartphone technology and the ability to record what somebody's already doing as part of their daily life and turn those into signals that are relevant. So I'm going to quote some of our 2015 work here. The next couple slides are based off of this patient population, where we've got users who have attempted suicide, 125 of them. And we have some neurotypical controls. These are age and gender match controls. And what I have from these people in particular is their Twitter data. So I know the date of their suicide attempt, and I've got tweets from prior to that attempt. So here's the histogram of the age and gender distribution of this, and you'll note that most of these people are in their sort of young to mid-20s, and the vast majority of them are female. So keep that in mind in interpreting these results. This is primarily a sort of teen and 20 female population that we're talking about. There's real data ahead of this. There's some not kind words that are said here, so I apologize if I offend any of you guys, but it's coming from real data. I didn't say it, I swear. If we take all of those tweets and just try to do some exploratory analysis, let's see what sort of pops out. So what I have here is like a Venn diagram and a word cloud have a child. This is what it would be. This is a Venn cloud. On the left, in blue, is, any word can only show up here once. It's either a blue word, a black word, or a green word. And if it shows up with higher probability from the users that would attempt to take their life prior to that attempt, it's going to show up in blue. Right? So these are words more likely to be said by someone prior to a suicide attempt. If it's more likely to be said by a neurotypical, it's in green. And if it's about equally likely to be said, it's in black. And there's a whole bunch of parameters there that I'm not going to talk about. But the way to interpret this is that users prior to attempting to take their life say things like, I'm, do, how, want, feel. And people that are neurotypical say day, lol, night, girlfriend, boyfriend, birthdays, a whole bunch of other things. And then these are all sort of things that everyone says, including some bad words. Does anything stand out to anybody? Any immediate signals?
In the middle of that, but they're more kind of, suicidal is sort of, hurt, pain, all sorts of things in that side.
Yeah.
More than, obviously, it's pain.
So, almost everyone usually goes to the emoji. I figured after last night's event, that would be the first thing anybody said, but we'll get past that one. You're exactly right. There's self-focused language and emotional language. You actually got the point from the next slide. I don't know how you did that, but that was very good. And so this is actually a well-replicated finding that people that are suffering from depression talk about themselves more. Whether that's introspective or they're talking about being alone more, it's perhaps a combination of these things. But this sort of falls out of the analysis. So this is actually really interesting. That the emoji are something that people prior to a suicide attempt use less. So it's not that they don't use them. They do use emoji. And in fact, there's a couple, I covered them up. There are a couple emoji that they do use, like heart-related emoji that they use more frequently. But sort of the general use of emoji to be present in their tweets is sort of something that's more neurotypical. What does that mean? I don't know. But keep that in mind. So we also have some emotion classifiers based on the text of a tweet. I can guess what the emotions are in that are sort of trying to be conveyed. And so what we can do here is, this is the y-axis here is the percentage of tweets that are tagged as having some emotion, right? So I'm not going to go into how we did all these things and what it means, but you can say that basically this is the line for the neurotypicals. And so something around just a bit more than 50% of a neurotypical's tweets has some emotion present in it. And this is actually the standard error around these things. It's actually a pretty tight bar. And what we've actually done here on the x-axis is laid out the people that have a suicide attempt. I've zero aligned all of their suicide attempts, so everyone attempts suicide right here. And so what you're seeing here is the average, the percentage of their tweets that have some emotional content. And you can see that the people that attempt suicide, the percentage of their tweets that have emotional content is higher than the neurotypicals. And in fact, that increases after the suicide attempt. So now put that at odds with what we got off of the last slide, that people that are neurotypicals tend to use emoji more, but people that will attempt suicide, and even after the suicide attempt, use more emotional words. And so I thought, this is crazy, I must have done something wrong, but at least one of my compatriots who has attempted suicide said, yeah, those emoji are sort of like cartoon emotions. My emotions are more real than that. They can't be conveyed by a picture. That's an anecdote. I don't know if that's right or not, but that I could see that having some explanatory power here. Point being, there are some quantifiable signals around the presence of emotions in suicide attempts that fall out of some of this analysis. This is not hard computer science stuff. It's actually pretty easy. I'm actually a terrible computational linguist, despite the fact I worked in a natural language processing group. Terrible linguist. But some stuff falls out of it, and so there's sort of some interesting real power there. If we actually look at the individual emotions, it's a very similar plot here, except I've only plotted the angry posts on the top, and I've only plotted the sad posts on the bottom. As you can see, there are some quantifiable effects sort of right around the time of the suicide attempt. You see spikes in anger and sadness in what someone is talking about on their tweets. Is that enough to definitively figure out if someone is at risk? No. But it's sort of interesting. There's not only this sort of this distal risk that pops out of it about somebody who's sort of generally, who will go on to attempt suicide, but also there are some proximal signals that are falling out of you in this simple analysis. Does that tell us how to intervene? No. But it's an interesting signal to look at. So intervention should be what we all care about. So let's do that. Let's run the thought experiment. How can we design a piece of technology to detect when someone is at risk for suicide? Right? It's entirely doable. And so here's our first attempt at it. I kid you not, the first thing that I ran. I've got 4 people that are present here. The 2 blue would go on to attempt suicide. The 2 green are the neurotypical match controls. And so this is their score over time. And so higher is more at risk. So I want you to take 2 things away from this plot. One of which is there's more blue above the midline and more green below. So there appears to be some signal, there's some separability here, but it's a wicked mess, right? People are all over the place, variability is high, and there are times that blue people look green and green people look blue. So just layer in the rest of the data there. It may be hard with the lighting to see all of this, but it's actually, you can see the exact same thing holds true here. There's more blue above the line, more green below the line. It's a wicked mess. And this is, let me emphasize, this is the first analysis that we ran. This is super, super simple. There is definitely some signal here that's relevant to this. So you should ask the question, how well does it work? So I'll only give you, if you interpret rock curves, you're welcome to look at this rock curve. I'm not going to go through explaining the whole thing, but this is sort of in full disclosure mode. This is our full rock curve. But one operating point to think about is if there's a point in time where I can identify a non-trivial sample, say 1,000 people or something from those 40,000 samples we're looking at here, that may or may not be at risk, right? And if we take the 1,000 most highly at-risk people, half of them would actually go on to attempt suicide. And so that's way, 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 way higher than what you would get from a random draw of the population. And in fact, it's higher than what Franklin says that the clinicians are capable of doing. And this is just running a simple algorithm against somebody's text. Is it perfect? No. Is it going to work as some part of a screening? Maybe. But this is the real question. This technology exists. How should we use it? I could go out and run it on all of Twitter and find all these people that are at risk. And then what? What's the next step? So I have some ideas, but that's what I would hope we would talk about here and how this can be integrated. One thing to point out, if you did get everyone who's at risk for suicide into care, at least in the US, we would need 20 times the clinicians we currently have. So that's not going to work. So we need to be a little bit more clever than that. So this brings up the first of these gray areas, and perhaps the largest. There's a privacy is often talked about as some sort of ideal and some absolute. But it's never talked about what the cost of that is. Or maybe in the terrorism example, right? They talk about the cost of counterterrorism sort of stuff, right? How do you, if you give up your privacy for security, what does this look like? But this is actually a very interesting spectrum that we're on. What's the trade-off between privacy and saving lives with this simple intervention, right? If this was used to find people that are at risk, and the public was willing to accept that, what would that look like? And how should that be designed? I don't have the answer there, but this is one of the gray areas that I hope we'll talk a bit about. And this is not just suicide, right? I gave you the sort of dramatic example. We've actually run this, these are 10 that we published in I think 2014 or 2015. We've got 16 conditions we've run something on that we have some signal for. And the one that I can't ever seem to make work is seasonal affective disorder. I don't know what this is. Maybe we're all affected by it. But the fact of the matter is that this sort of quantifiable signals are present for a whole wide range of conditions. And so how this tech is coming, it's not just for suicide. There's a bunch of mental health information encoded here for a wide range of mental health conditions. How should we use it? I don't know. So let's go even simpler. Never mind language. Never mind this natural language crap. Let's just count. Let's just count things. How many times have a person posted per day? That's something we can all sort of get our brain around, I think. At least I can. It's not indicting any of you. It's more my problems over here with linguistics. So let's do the same sort of thing where I'm going to zero align everybody's suicide attempt. And I'm just going to count the number of posts that they have before and after their attempt. And so what you can see here is there's a spike around their suicide attempt. They're posting a little bit more on average around their suicide attempt. There's also an increase in variability. There's more variability around that suicide attempt. That's kind of interesting. It's not really super powerful. It's certainly not enough to do anything sort of for that alone to detect this. If you're posting more, it doesn't mean you're at risk. But there is a signal even in this very, very simple analysis. It's more interesting than that. If you look at the people that are involved here, there's actually two distinct patterns here. There's a subset of them that entirely drop off social media days and weeks before their suicide attempt. And there's another subset that drastically increases their posting around their suicide attempt. So this is not meant to say that this is necessarily should be used for anything. It's meant to illustrate the point that we often treat these problems as if they're population level problems without thinking about the subpopulations that are there. The way in which we do a lot of this study is not based around individualized and personalized analysis. And yet, the person's interaction, the way in which a person interacts with social media is going to vary very differently what sorts of signals they would spin off here when they're at risk. And whether they're reaching out for help or whether they're withdrawing. So with that in mind, let me give you one. This is not yet published work, so everything else that I've talked about has been peer reviewed in some way. This has not been, full disclosure. But this is around sort of personalization of analysis here. And so this is, so we're skipping the second. We'll come back to the second of victims' points. But we're going to go on to the third. So our data helps was mentioned earlier here. Thank you to anyone who has donated your data through our data helps. This is a data donation site that we set up to, so why am I saying this now? Sorry. This is the population that's going to be used in this next result that I'm showing you. So we set up this data donation site to allow people to donate their data for science. And so Quantify collects this data, de-identifies it, and makes it available to academic research institutions that want to do research in this space. So this is originally set up to do suicide prevention and help out. There was no suicide data sets aside from what we had built. So this is meant to sort of get a very wide aperture view of suicide attempts. And of course, it's gone on to do some other things now. So we're working with the University of Maryland on their schizophrenia study and a handful of others that I probably shouldn't say publicly. So if you have a data collection need, let us know, because we have a lot of stuff already built. So what this really is a very quick onboarding process. It takes about 5 minutes for a person to go in and give us access to as much or as little data as they want, and fill out a short withdrawal questionnaire. So at Our Data Helps, we're able to collect Facebook, Twitter, Instagram, Reddit, and Tumblr. It's amazing that I know those things. I'm a bit of a troglodyte when it comes to technology. We have some wearable sensors that we can collect, and so Fitbit and Jawbone, despite the fact that Jawbone's about to go belly up. So I don't know what the next one is going to be, but we'll try to collect that. We have some activity monitoring stuff from Runkeeper and Strava, and then we have some prototypes for some more interesting data collection. Slack, Apple Health Kit. We actually have some monitoring things for a computer to see what your computer activity is. So the point being, modulo these prototypes, anybody can go in and donate some data. And so we took a subset of the people that had donated Facebook and Fitbit data that was co-occurring. And so what we did here is to sort of look at the relationship between movement and mood. And so at a very high level here, the individual observations are days. So on a day, let me see what your Fitbit tells you, because there's a whole bunch of stuff about your movement and sleep, and let me see what your language of your Facebook posts tell you. So this is us running a bunch of our analytics on the language of the Facebook posts. And so what I have here is a correlation matrix. I apologize, it's a bit washed out there. Showing the correlation between these two sorts of things. And so you will get a dark blue dot if these things are tightly correlated positively. And so if one goes up, the other goes up. You'll get white if there's no statistically significant relationship, bunch for uncorrected for all the things that are going on here, and red if it's tightly negatively correlated. And so you can see this tight diagonal coming all the way down here. That means this is because I have the exact same analytics and measurements on the rows and columns. Okay? And so the way to look at this, the really interesting, there's a bunch of stuff you could do in the quadrants and relationships between various mood classifiers, but the really clever, cool thing in this space is looking at the relationship between movement and mood. And there's one thing that we can measure from Fitbit that reliably correlates with a whole bunch of mood. And the rest of the space is kind of white. What the heck does that mean? So I'll tell you the one thing. You want to guess what it is? Anybody? All the things your Fitbit could tell us. What would you guess is most likely to correlate with mood? No? That's what I thought too. It has to do with your sleep. It's actually how many minutes it takes you to fall asleep. Fine. Great. So what about all those studies that say that exercising is good for you and movement is good for you and doing? What does this mean? I don't have a lot of evidence that there's relationships there. It's actually not true. I've lied to you. I do have plenty of evidence of relationships, but they're not the same across the population. And so in fact, to your point, if you look at my wife's data and my data, our lives are entirely discorrelated. If I'm moving, I'm having a good day. If she's moving, it's a terrible day. If she's moving, it means that the kids are harassing her and keeping her. If she's able to like sit down and relax on the couch and everything, like, this is a fantastic day for her. And if I'm sitting still, I'm in like meetings all day, and I'm just miserable. And so there's interesting. This is like a quick anecdote for a larger point here that movement, and more to the point, movement as recorded by Fitbit, and mood, or more to the point, mood as recorded by Facebook posts, are different and personal. And so the point being that I didn't actually say what these are. So if you look at the individual relationships, the individual correlation matrices, you actually see some really, really strong correlations for different people within that movement and mood space. They're just not in the same place. So you go to average across the population, all disappears. That's not meant to say anything other than there's very clear evidence that these things are different. And so how do we use this to inform care and inform treatment? I think I was joking with some of you earlier about yoga. If yoga is a thing that you think is a reasonable approach to care, and you would like to prescribe that to someone or suggest it to someone, you probably shouldn't do it if they have a dog or a small child, because they're going to get knocked over. Right? It's like yoga with small children doesn't work. At least end of 2 examples I've got. You just can't do it. But that said, someone who doesn't, perhaps this is a totally reasonable and fine thing to do. But this is a simple way of saying there are ways to inform and change care based on the data that we could capture more or less automatically. How should we use this? It's possible, but what should we do? So I'll very quickly go over the last of Vikram's points here about artificial intelligence and chatbots. Yes, I know, I'm almost done. Shh. So we work with this company called 7cups. You guys know 7cups.com? If you don't, you should check it out. Never mind everything else that I've said. Go check out 7cups.com, 7cups.com, and this is a peer support system that I believe is the largest peer support system in the world. They've got 190 some odd languages that are supported, and they have 1 million conversations a month, 1 million people that have conversations a month. And so really what's going on here is they have active listeners. This is not care. It is just like caring human beings that want to talk and provide emotional support. And so like the really cool thing is we have their data. We've been working with them and building the data science backend for all the stuff that they're doing. And so all this data that's flowing through, we're able to capture, we're able to help them do better at listening. So the first thing that everybody thinks of is artificially intelligent, whatever Vikram said, right? Artificially intelligent chatbots. Yes, clearly you could do that. Yes, in fact, you could do that. We are doing that. But that's not the interesting thing. And let me point out, I was highly skeptical of this idea. Like, this is a sort of by definition, where we're talking about connecting humans, and this is a very human thing, getting psychology, getting people well. It turns out for a subset of the population, a non-trivial subset of the population, talking to a human, even anonymously and over text, is anxiety-inducing. And for some people, talking to a chatbot is not. I wouldn't believe it unless there's data there to say it, but there it is, and so I'll eat my words, and so we'll go and build the stupid chatbot too. That's not what I wanted to talk about, though. We are building some stuff. It actually does really cool things, and it's sort of semi-self-aware. It knows that it's in the United States, because that's where our servers are, it turns out, but it doesn't know what state it's in, which is probably actually true. So we've been doing a bunch of interactions with this. I would have given you transcripts, except we haven't. I didn't get a chance to run it by the 7cups folks before I just presented it here. Active research right now. But let me talk about some of the things we are doing that are not that, but are related. In fact, the same technology is needed. So we use this to help train the listeners. And so you can, before they're about to say something that we know is a bad thing to say, because we have evidence of good listeners and bad listeners, we can stop them and say, if this person's saying don't be stupid, there are better ways to do that. We can stop them from sending that and saying, stupid might not be the word you want to use there. So here's actually, did you mean perhaps less than ideal? Right? What are the suggestions? Here's some ways in which you can improve the way in which you're interacting with these people on the other side that might make it better. So this is one way that tech is empowering humans to do their job better. Right? It's not replacing the human at all here. It's just helping them do this better and hopefully offending less people, which I am clearly not doing. We can also analyze their language over time and see, are they getting better, are they not? And so this may, in my wildest of dreams, is going to replace a bunch of your psychometrics. We can stop asking them questions and just start analyzing their day-to-day interactions and tell you how people are doing. And then the last sort of thing is like, which of these interactions, which of the aspects of the 7cups site might a person need? And so this is a personalization story. How do we help them understand, well, basically, based on people that we know that are having similar issues, that are talking about the same sorts of things and talked about their dog, you should not go the yoga track, but here's this other meditation thing you might want to try. None of these things is totally right. They're all sort of, I think, closer to right than the thing that everybody first leaps to around chatbots. But there's plenty of ways in which data science can sort of empower what's going on. So with that said, there's a couple gray areas that we've raised, and I hope that we'll talk about these throughout the course of this. Privacy versus live saves, and how do you do tech-empowered care. And I hope that I convince you of this, that there's tons of power in that white space. That mental health is individualized, and we actually have ways of capturing that. How should we do it? I don't know. And ultimately, there is revolution coming. What do we want it to look like? I will leave you with this. I've had this slide in almost all my presentations. It's very appropriate here. I can only see a short distance ahead. I can see plenty there that needs to be done. Thank you very much.
Thanks, Glenn.
Thank you.
Questions, please. Don't be shy.
I don't bite. I swear.
I have a question.
Yeah.
I was wondering, when you guys are there's a trace all the data of people who are trying to seize them. So, for these people, you collaborating with some healthcare organizations. So, how do you know when they're trying to do that and how to monitor it?
So the study, the 2015 study that you're talking, this is the 125 people we were looking at.
Okay.
Is that what you're talking about? The couple suicide examples that we talked about?
Yeah, so you
Okay.
know
So-
when they try.
So this is actually people that are talking publicly about their suicide attempts
Okay.
and talking about the date of their suicide attempt. So it's not working with medical data at all. This is entirely outside the medical space.
I see.
But they give us enough context to know exactly when the date is, and we can go back and look at data prior to that. Public data, all this is public data. Yep.
Sorry, I arrived late, so possibly I've covered in the beginning, but I was wondering how do you establish the cutoff in terms of language and expression? So for example, if someone mentions that somehow is a sad day and you know, where is exactly the cutoff to decide that that person may have, you know, like passive or active suicidal thoughts?
So I didn't talk about that at all. There's two ways in which I don't think that's an entirely reasonable question, but it turns out it doesn't matter. And so the rock curve that I put up there was meant to say, I actually don't know where to place that cutoff. And the real way in which we should do that is not by looking at the data, it's by asking about what the next step in that process is. And so the real question that we want to know is how many people could we screen positively and get into care? Because currently the problem is not who's at risk, but how many people could we do more care with? And so the real limiting factor right there is the next step in that process. At some point in time, if we're able to scale it up so we don't need 20 times the clinicians that we currently have to deal with the people that are in crisis, then we should revisit this and adjust that threshold. But it turns out taking the people that are most at risk are actually
Yeah, no, totally. I mean, not wanting to play devil's advocate, but then like a possible problem is that we're like medicalizing or, you know, like defining as a disease or abnormal or at risk behavior that is normal and reactive and adaptive. You know, I mean, this is more kind of like a philosophical open question and discussion, but yeah.
Yeah.
Food for thought, I guess.
Yeah, there are plenty of sort of pragmatic constraints that are going to prevent us from having to answer that question for a bit. But you're exactly right that at some point those pragmatic constraints will go away, and then we do have to figure out what it really means. And in fact, I hate the labels entirely. And we very rarely talk about the individual conditions. We talk about sort of the person that's underlying the condition or the individual traits that we're seeing. And so that sort of suggests that perhaps there is, in the long term, the right answer here is that none of these things are really, they're a convenience for the insurance company, but it's not actually relevant to care. And so actually getting past those labels is something I would love to do. And so then this sort of goes away as well. It's a really good point. Yep.
And how long does it take to kind of get an individual's baseline? Because I mean, you were looking at things to sort of a signal from a lot of data.
Yeah.
Which is great, and obviously it's retrospective, but if you're looking prospectively,
Yep.
I know I would be your really annoying person with one, session I'm not part of it, but
Yep.
if someone's using it on a weekly basis or whatever.
So this is a really complex question, and I have only a little bit of an answer. So it looks like for a lot of the algorithms that we're running, a couple hundred posts or tweets rather than posts is sufficient. Yeah, so a tweet is 140 characters, so it has to be sort of tiny. And so it might be that we haven't done exactly the same baselining with Facebook, but it's sort of, you have to have enough text over enough days to give you some notion of what that variability is. There are some ways to estimate it, we haven't yet, at least for the Twitter side of things, where we need like 300 to 400 posts is where we're about comfortable. So that for some people is in fact what you do before lunch. I don't understand these people, but for many of these people, in fact, what you really want is you want to be able to observe the normal behavior over a number of weeks or months. And the kind of nice thing about this is we can do it retrospectively, at least with the things we've talked about here, is that the ability to sort of say, yes, I'd like you to analyze my data, gives me the ability to go back in time as far as the company will let me to go get, so Facebook will let you go back indefinitely, Twitter will let you go back 3,000 posts. And that's often enough to build a baseline.
So,
You're going to cut me off and I can't do it anymore.
No,
right?
we've
Okay,
got a
good.
couple minutes, go ahead.
so speaking of the retroactive
Mhm.
observations, how do you envision this being integrated into these platforms so that real-time occurrence can actually be observed and marked and intervene maybe at some point?
You're talking about like, how do we integrate this into Facebook?
Yes.
The question? It's a fantastic question. I hear that someone is here from Facebook and may talk about it, but I don't know. The companies are doing a good job of trying to understand these problems, but they're not being very forthcoming about the way in which they're creating their interventions. So it's not actually clear where this tech might plug in well. From the outside of things, most of the stuff that we think about from the ethics standpoint is opt-in. And so rather than doing this sort of like all the people on Facebook that are at risk, or all the people on Snapchat that are at risk, and finding a way to intervene with them, we're saying there's enough people that actually want care and have asked us to do the analysis of their data. Let's start with them. And the hope is that, and I don't think that's the right answer in the long term, right? That's very far on the privacy side of that spectrum. But I think it is the right answer to start the debate and to say, here's like the quantitative information you need. The people that opt into this care get, you know, X, Y, Z benefits. And here's now public, here's a debate. Let's have this debate. This is what it does when people opt in. Should we be running this on everybody? What should this look like? Because right now, I don't think that's well understood. And the Samaritan's Radar, is everybody familiar with this?
Yeah.
A couple? Not everybody. Okay, so I'm going to say this anyway. This is a very well-intentioned way to sort of put some suicide prevention work into that space and to sort of scale it to everybody, but it didn't work well. And so what they had done is they built, this is the Samaritans, the UK Samaritans. It's a super venerable organization. They're doing this longer than I've been alive. And they, with all the best intentions, built a program that would go and attach to your Twitter feed and listen to all of the people that you follow. So this is anyone that you decide you want to get their Twitter updates, you can get this data coming to you. And they would analyze it and look for things that, if they said something like, I'm going to kill myself, some sort of blatant suicide-related phrases, right? And they're not perfect, but it was enough to, this could raise a flag, and it would give, the way this program was set up, if you attach this to your feed, anyone that you follow that says something like that, you would get an alert. And so what has happened here is actually there's analysis going on of a person that has not opted into that analysis. And some would argue this is healthcare information that has been granted. And I think exactly where those lines are drawn, I'm not going to say anything, right? That's a different question. But at the fundamental ethical question, you're providing some information about someone who might be vulnerable to a third party. And so it's clear that the public did not like that plan. But there are other things we could do here, right? What if that was only for a medical professional? What would that look like? What if it was only for someone who had a special state license that was allowed to do these sorts of things? What would that look like? I don't know. But there's other things we can do there, is the point. And so there is technology that has been tried and has not gone well. But I'd love for the next time that we do this to go well instead of to go not so well.
Just to say, so we do have someone from Facebook here in this room this afternoon talking about Facebook Compassion Research Suicide Prevention Support. So I'd like to work on that. That gives me a good chance to advertise this afternoon.
I'm guessing, I was hoping that they were in the room. They're going to say, oh yes, I'm from Facebook and blah, but I guess not.
Yeah, you're talking about the data donation site.
Mm-hmm.
And PhD computer science student working on the machine learning approach for regression analysis.
Mm-hmm.
So is there any possible chance that I can request for the data set?
Yep. Yeah, so if you email us, ourdatahelps.org is the site. If you email me or if you email us, there's a quick approval process. There's a board of mental health people and technology advocates, and I don't know. There's a board of people that approve every proposal. It's a short couple of paragraph thing, and as long as it's, I mean, what you're doing is the sort of reasonable stuff. If you're not for profit and if you're doing reasonable research, you'll get approved. And so definitely reach out to me, and we can talk. I'll make sure that it gets through. But the point being that that's the whole idea, is that we should be able to package this up and hand it to people who want to do research, so you don't have to go through building all these things and maintaining them like we have.
Okay, so one advantage of being chair is I can ask the final question.
Great.
My question is, well, it's around, you publish more than me, right? So
it's computer science publications though, so like, yeah.
Well, I've done some of those, they're not trivial. So as someone running a startup, how do you manage to still be involved in academia?
It was a deliberate choice. So I will tell you a bit about the founding of this company. It's not super public knowledge, but a lot of this came down to the fact that while I was doing some of this very, very initial research at Hopkins, I realized that Hopkins is not set up. Hopkins is a great institution, both for interdisciplinary research and for sort of biomedical related stuff, and they're attached to this hub. Fantastic place, and the sort of what I would imagine was the ideal place to start trying to build some of these things. But what I realized is that this university is actually not set up to build sort of deployable, scalable, and maintainable solutions here. And so we made the deliberate choice to sort of, we'll try to blur these lines between academia and industry and start the company with the deliberate intention of publishing everything that we're doing to maintain the science aspect of it, inform the rest of the community, but at the same time, build sustainably, and be able to maintain these things over the long run, not based on university programs and everything else. And so the only way that we've been able to do it is in sort of deliberate, right? We make sure that every year for ACL we're putting out a couple of papers at least, and so in fact most of the companies there, I'm here and they're over there presenting our work right now. But it was not, I think left to my devices, if it was not a deliberate choice, I don't think it would have gotten done, because you're right, there's 10,000 other things we should be doing. But we made that choice and I've stuck with it.
Okay, brilliant. Let's thank Glenn again.
Thanks, guys.